The session for this afternoon, which I've already mentioned, that it is a great honor, privilege, and we really appreciate this moment to share the knowledge about the initiatives which are aimed at the nation at large with those that are vulnerable with the life-limiting conditions, and see how best we can work together, empower our colleagues at the front line with the knowledge from each and every setting, whether it is at the clinic level, community level, hospital level, or even in the other educational sector, so that we can all see how best we can just join hands to address the non-communicable challenges that are facing our patients and their families. So my name is Tebello Marichavalipane, founder and CEO of Starlight Oasis of Hope Hospice, which is a charitable organization registered here in the United Kingdom, as well as registered there back in Lesotho. And the idea has been invited is around the palliative care and the rehabilitation part of it in order to ensure patients have comfort. So,
yeah.
Okay.
Let me try use my hotspot in an unstable.
Okay, ma'am. Okay, let me minimize here so I can see. Now, Starlight Oasis of Hope Hospice, as I mentioned, it is actually existing across these two kingdoms, here in UK and Lesotho. And we also work in partnership with the Welsh organization called Dolan Cymru, which is a charitable organization that has got strong links with Lesotho in the area of education, health, and culture. And the relationship between these two countries have been in existence over 35 years. So some of you might be aware that our patron is Her Majesty Queen Memasnati, and indeed last year, just over a year ago, we were just given the privilege to launch the movement officially at the Royal Palace. However, the initiative has been the brainchild of myself since 2010, but then it became public 2017 when I started an active advocacy around the subject. Our chairman is Dr. Paul Myers. He is a retired GP here in UK. He has been a chair of many organizations, including the Royal College of GPs in Wales. And he's also the chair of the Dolan Cymru Lesotho link, which I've just mentioned earlier. And that is me, and I'm still finishing my thesis for palliative medicine at the moment. I'm just about to submit in 2 weeks' time. And my subject, my topic is around establishing the facilitators and barriers of establishing palliative care within SADC countries. And I really want to do that topic justice, because it will help tailor so much that will help most of the SADC countries. However, saying that, it's also good to mention that palliative care seems to be existing, even if it's in a small scale, in the other 15 countries within SADC. Out of them, it is ours only, being the 16th country within that community that still needs to do a bit of work. And I believe we are still already establishing ways as we do even today. So this is all that we know about our country. Each one of us is familiar with this information. I'll pass quick. But I want to mention that as I really stated earlier, that we have been really challenged around the communicable disease. But at this point in time, we seem to be seeing a chronic rise around the cancers, diabetic complications that come with hypertension. We have got issues around people with disabilities, whether these are inborn challenges, congenital ones, or maybe disabilities as a result of car accidents, or disabilities around maybe people coming from the mines with chest issues or even physical disabilities, but also disabilities that are secondary to chronic conditions like progressive cancer challenges. Now, we still also have rising issues around mental health and substance use. I'm not sure if you are aware with the latest statistics that last month, as it was the World commemoration around raising awareness about suicide. We are actually #1 worldwide with a high suicide rates, and that will be around issues of anxieties, depression, and everything else. We also have challenges around dementia. We need to really escalate and scale up our awareness methods, because most of the people with these issues are really named, as we all know, that they are witches, baya lawyer, ditaba tsa bona di ba hlotse, so ke ba ba fumane hoduma ntlo, ke ba ba fumane di-gating tsa batho without any clothes. And yet this is an issue that is facing our elderlies. Now we also have these issues around kidney failures. We know how much there's a big campaign in every media house of dibotlolwana concoctions, cocktails of medications, which we have got no clue about the measurements, about the ingredients which are active, which might not be helpful for the liver and the kidneys. And you'll find that we are having now bigger numbers of people with the kidney issues, sometimes being complications of the ARVs or any other issues like diabetes and hypertension. As we know, they really attack those essential organs. Now, we still have challenges around HIV, then all the complications that come with it, sarcomas and all that. So why would I bother? Somebody might ask. If I say I've been in UK nearly 20 years now, why do I bother about Lesotho? Why can't I just be content and be comfortable? I've got my husband and our 2 blessed children here. So it is because it is something that is really been born out of the spiritual journey I went through. It's actually a calling and a purpose for why I exist. Because the care gap could not give me rest, that not only from the close cycles or my family members that have gone through challenges with their life-limiting conditions, especially cancer, but also remembering some of the faces that could not leave my mind. As I used to work in Queen Elizabeth, as I mentioned earlier, at times would be rotating and one would find ourselves working in surgical wards, of which you will meet patients that are just lodging overnight on their journey to Bloemfontein for their cancer treatment. And most times they would be in agony, with pain, distressed, really frustrated, and fearful of what the future holds. And in those days, I know very well, we used to only primarily to have for diclofenac injection and pethidine, which were only prioritized for those patients that are coming from theater, who have just had their operations, not for cancer patients. And these people would be in agony, crying. Now, the journey with Starlight Oasis of Hope Hospice started with an inception of a consultancy organization, which was aimed only at the time in 2017, just for capacity building. But then, as we know, we face so much challenges in our nation with regards to funding and new initiatives. How do they really get a secured budget? It was really taking long for us to find a way into trying to empower our colleagues on the ground, build and raise awareness on the needs of our patients with chronic conditions, including cancer being the primary focus at the time. But in 2018, we really had the memorandum of understanding with the ministry, because 2017, it was just to do proposals, raise awareness, and really make a case statement of where we believe we can play a part in that care gap, which was very clear. And I'm grateful that Jojo Samanyu in the room. He was part of those people at the time that we were just having meetings and exploring how best things can move for the benefit of the nation. 2019, as we realized that the journey to empower the professionals with knowledge, or even raise awareness about the need for morphine for the patients was taking longer. We then established this charitable organization that I'm now presenting under, because we realized we have to run quick. The suffering is felt by the vulnerable patients and their dear families. Now, all that has progressed here in UK 2020. We got the charitable status. We are on the government website. We are known by the government of Wales and the main government here in England, so that they are very much aware that one of their Commonwealth countries is really striving to establish and support what is going on the ground. So as I mentioned, 2022, we publicly announced the movement for the entire nation. Our intended work is around the vision we have, hope. What is hope? Really resuscitating and reviving that which might have been lost when somebody receives a diagnosis that is really impacting on the way they see their future, the future of their livelihoods and that of their families. So it's about hope and compassion through life's journey, whether it is a urine diagnosis, urine treatment journey, urine end-of-life care, or even urine the bereavement and aftercare. So it's about supporting and ensuring that we work together to provide and achieve the best outcomes, working with all the partners, our ministry mainly, and all the stakeholders that are involved in this space. Now, it's about patients again. Why did we find the patients being the need? It's because it took so long to change people's mindset, attitude, and understanding around what is all this woman from UK trying to say and establish here at home. And I had to really be patient with myself, patient with the Lord that gave me the vision, and patient with the process. Why compassion? Because we want to promote a culture where people feel valued and treated with dignity and privacy and respect indeed. And it's all about survivorship, supporting those individuals from that journey on the continuum from diagnosis through treatment journey, even beyond. Beyond could be whether it's end of life and then it's a bereavement, but then the survivorship would be those victims of cancer and other life-limiting conditions, and even supporting their families to have a better quality of care even after such challenges. Now, our operational pillars are based on advocacy, which we have started around 2017. Is an ongoing journey, and I've realized is actually a life mission, because it is actually through the media houses, whether it's over the radios, newspapers, regionally, locally in Lesotho, even internationally. It is also about ensuring that we exhaust all means of trying to raise awareness about issues around chronic conditions, cancer, palliative care, and hospice care, because most people still believe for palliative care, it's only about dying. Now, we also have the capacity building, which I think it is the purpose of our meeting today, to see how we can best work together to capacitate our frontline teams, even the policymakers, to raise awareness in that level and arena, so they are aware as they make policies that they need to really create the budget or approve the budget and strategic plans that respond to the challenges around non-communicable diseases. Care and support, what are we talking about? It's about supporting the patients, supporting their families, really capitalizing on the manner and understanding that palliative care is about the total care model, which was founded by the founder of palliative care here in England, Dr. Dame Cecily Saunders. She was originally a social worker. And then she realized that she could not really respond properly to the needs of the patient. She went and did nursing. She still realized her knowledge in nursing and being a social worker still can address all the challenges, whether it is physical challenges, pain and other symptoms, whether it is social challenges, people are losing their jobs, they are distressed, they are losing their own positions in the family. Instead of being a father that is providing, they become, if that is the father poorly, the children and the wife are the one looking after them, and they lose that sense of identity in the family. They lose their jobs, they lose their income, they lose the future of the family if a person involved is the breadwinner. And that level of support also moves towards a spiritual support. How do we support them? How do they find the meaning in life and even with their own existence? Why God? Why me? Why now? And we need to support them through counseling, through pastoral care, and also psychologically. These patients with non-communicable diseases, whether it is a complicated diabetes, which has damaged the kidneys, and somebody has got now chronic issues, whether they have got wounds that are not really healing in their feet, they need to go through amputation or anything like that, they go through a lot. Psychologically, they become distressed, anxious, and depressed. We need to support them. Now, around the same support and treatment combined, now we are talking about the medication. How do we respond properly? Utilizing the essential medication list as recommended by World Health Organization. How do we utilize the World Health Organization pain ladder to ensure that we don't just give a paracetamol for somebody who is experiencing moderate to severe pain. We don't just maximize by giving people only a few doses of Tramadol of those that are in severe pain. Whereas somebody is going far, is only getting 6 tablets of Tramadol, which we know is 3 times in a day. It means it only covers 2 days, and yet the patient would be expected to come back in 6 weeks or in 4 weeks or 8 weeks. Then how do we really say we are providing support? So we are in that space to work with our ministry, with our international partners, to see how best we can really address these issues. Yes, as I mentioned, our first operational pillar has been around advocacy, raising awareness and ensuring that we all represent the patients well, we all represent their needs, and then we work with everyone else to make sure that those needs, we bridge the gap around that. I attended an APCA conference last year after our launch, and then in Uganda. Dr. Zippy is one of the pioneers of palliative care in Kenya. She founded the first hospice in Kenya, and she founded the first association around palliative and hospice, which is now called KEPCA, Kenya Hospice and Palliative Care Association. And she really set something that always stays with me. Without empathy and compassion, you will be doing advocacy for nothing. We have to know what the needs are, identify with such needs, own them, and carry a burden, believing in them and mobilize and also influence others to support the change in policy or program, and also to bridge those care gaps and ensure whoever needs that kind of care becomes the ultimate beneficiary of such a movement. It's about communication. As we communicate it through radio stations, TVs, journals, international newsletters, or even at the press, at the conferences, just like on Monday, this week Monday, I was invited to present the palliative care initiatives about the people of Lesotho at the Welsh government. The conference was there because they know my noise even here on this land. Then they just gave us the platform to say where we are and what is happening and what we believe will take us to the next stage. And it is all intended about an expected change. Our priorities, the Starlight Oasis of Hope Hospice, is about responding to the voices of the people of palliative care needs, them and their families, also empowering our colleagues in the health and social care space so that they can be able to be confidently able to really care for the patients, support them, and then we will step down all those trainings and impact to the community level, our village health workers, to really tailor and customize the training that will be relevant for them to support the families in the community so that we don't see the patients who are actually into the end of life stage being dragged on that thin mattress into the back of the van to the hospital where they will be there queuing in the cold, sometimes in winter, until they even die on that fan or as they enter the hospital or even as soon as they put the patient at the back of the van, simply because they didn't know that it was time to keep the patient comfortable, reassure the family, and support them accordingly. Now, it's about ensuring strategic connections that will enhance multidisciplinary approach, ensuring that we have got the doctors on board, nurses, pharmacists, psychologists, chaplains, physiotherapists, occupational health therapists, dietitian, everybody that is crucial in that space to support the patients, social workers, everyone. Now, improving the quality of palliative care, as I mentioned earlier, in all settings, clinic, hospital, home, community setting, or even hospice level. Then we just have to also acknowledge the need to play a part in the preventative and the primary level, just to ensure that we minimize all these issues to come to the level where palliative care will be needed. So that is it. And what is palliative care? And I believe you all are aware. I would love to hear what you like to say, but because of not being able to connect from individuals, you are all in one room and it might take time to get around. But the World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing problems associated with life-threatening conditions. What are life-threatening conditions? Any condition that changes the prospects and the future of how the patients will view their lives, view themselves in the space of this life. Now, as I mentioned earlier, total pain model was first discovered by Dr. Dame Cecil Saunders, who, as I mentioned, was a social worker, became a nurse, and ultimately did medicine at a college in London, simply because she realized that to make a change, there has to be a comprehensive approach that helps. So she was a multidisciplinary person in one body. In any sense, this is what she brought up for us to tailor and manage our programs around addressing psychological, spiritual, social, and physical challenges of our patients with these chronic conditions within the space of non-communicable space. Now, palliative care and hospice needs in our kingdom. We have got the land in Makaka. Our plan is to start with the community palliative care, visiting patients in their own homes, being able to change their medication to really ensure that we titrate the painkillers according to the needs of the patient, really attending to their wounds and dressing care, because most times some of them have got wounds that needs dressing so that they don't end up having these maggots because they don't have money to go to the nearby clinic to have dressings that are done regularly. Then we also have the plan to have for the daycare center where we can have for the patients coming once or twice or thrice a week, depending on the need, where they can be together, share their challenges, share how best they cope with the challenges, and even have for some trainings around self-help projects, so that if they have lost the jobs, then they can have for something they can be able to do that can still generate some kind of livelihood. And then ultimately the inpatient unit to offload our Sankatana for those patients that might not be feeling well after the treatment. They might have been admitted afterwards to our Queen Mamhato Memorial Hospital, but then it might be noticed that this patient is now for end of life, or their symptoms are quite complicated and might need specialist palliative care in intervention. Or even in the future, when we have our own National Cancer Center, we might need to vacate the beds quickly so that the patients do not overstay their time on the wards, to give room for those that are coming for their own chemo and radiology, radiotherapy. And if the patients haven't stabilized yet, still having challenges around pain, nausea and vomiting or other issues, then they can be admitted on a short term or even for end of life or for respite in our center. Now, we are on an ongoing journey with our ministry and other partners in building the documents, whether it is about the guidelines, whether it is about the palliative care policies. We are in the game, we are involved, and we are committed. Education and training, some of you might be aware, we are already on a batch 2 of our training. The first batch, we had 100 people that subscribed to it. On this second batch, because of the high demand, we extended it by 20. So 120 people registered on this current one. We have just completed the 5th session on Tuesday. We are left with 6 sessions. So we are left with 2 more sessions to complete this current batch. And our ultimate and future plan in the education and training is in the undergraduate programs. That is why we have got our 6 nursing schools involved in this current trainings that we are doing. We have already approached some of our colleges, including our National University of Lesotho, trying to establish some partnership with our universities here in UK that are very much supporting what we do in Lesotho. And we are trying to establish the steering groups that will see that the curriculum is reviewed and changed and adapted to the needs. And ultimately, we hope to have a standalone program in these institutions. Now it's still about the medication, how to make it available, how to make it accessible, because it can be available in the cupboard, morphine, no matter how many small doses we have, but is it accessible? Are we able to give it to the patient? Do we have enough assessment pain tools to really assess the patient's pain levels, to be able to know what we should be giving on that WHO analgesic ladder? NCD journey in our nation, we know is challenging. It's not a straightforward journey. It involves a lot of education, health education that we need to empower our patients with. It needs a lot of awareness raising amongst our healthcare professionals of how best they can support the patients and encourage them to adhere to our treatment journey. We have really been aware of many of the patients through those that have been contacting us who are very, very young in age, really at a very height of their career, who are breadwinners for their families, who are suffering from diabetes, renal failures, and complications around hypertension. And you'll find that some of them have suffered stroke as young as 35, and then some of them really don't make it, they pass away, or they are left on the wheelchairs. So it is quite unpredictable, and hence why I appreciate our journey with you to establish how we can really manage these conditions, then see how palliation can play part, as well as their rehabilitation. And again, the major space is still around cancer. World Health Organization key facts around palliative care challenges. In the Global Atlas of Palliative Care by World Hospice and Palliative Care Association, it says each year there's an estimated 40 million people that are in need of palliative care globally. 78% of them, they live in our regions, which are in the limited resource setting, low to middle income countries. And worldwide, only about 14% of those people are able to access palliative care. That is the challenge for us in Lesotho too. And then we just need to work together, national policies to be done, programs like the one you are working towards to be done and really be implemented effectively and with a promptness. Ensure we have got the resources to support palliative care, whether it is the budget, whether it is the medication and everything else, training, and ensure that our professionals are empowered. These are the urgent needs that needs to improve. The scope of palliative care is about ensuring that we are on the top game with pain management. We manage the distressing symptoms that patients experience, because if somebody has been lucky and they have had a couple of doses from Bloemfontein each time they go for their treatment, you'll find that they also experience nausea and vomiting. They experience constipation that comes with the use of opioids, and depression and other issues. How do we break news? Bad news is a great challenge. We need to have these strategies that have been found to be really key, and also to really give our patients hope despite the challenge that is being presented to them. If I can tell you my own journey when it comes to breaking bad news, I am my parents' only child. Unfortunately, 1999, my father, who never had any medical conditions, who had just retired a couple of years before from the mines, was just preparing to go high Smongong for the funeral. Yeah, our relative who was really brutally killed. I think that might have been something that was distressing him. Just after a day, he went for the post-mortem. And then the day after, he had to go home now to arrange the date of funeral, Simongo. Lapeng is Hasodi. My dad woke up, got himself prepared to go to the buses. He just collapsed. Nobody knew what was the reason. He got to Ward 5. At the time, I was on Ward 5 in our Queen Elizabeth. Unfortunately, he didn't make it. Within 24 hours, he had died. He had suffered a massive stroke. A year after, my mom, after leaving my house, Hafuso, she just had, just like everybody else, queuing for the taxi. There was still St. Bernadette. Car came from nowhere with that speed. It just mowed on the people that were on the pavement. More than 10 people died. I still don't know what happened to the rest of the many that were admitted, because I just told myself I don't want to know more. But what I'm saying is, when I got to our casualty, the news was broken in a strange way. And that's why I'm very passionate about this palliative care and how we break the bad news. Because I am looking for a person. I have just been called, being made aware of an accident of this nature. More anali 2 hours when we expected to go Hasudi. It is now 8 p.m. She left my house around 5 p.m. And this is strange. And then you will find her on the trolley. You'll find the body on the trolley. So this is still a challenge on how do we present this distressing news to our patient when they have got a cancer. How do we give them news without taking away the hope in them? that even push them to depression, and even sometimes don't even find the need to even pursue chemo or radiotherapy because they just lost hope completely. Then the ethical and legal and as well as professional issues. How do we enter into that space? Do we have any advanced care planning in our nation? We don't. How do we approach a mental care capacity for those that have lost the capacity, like those with the dementia, if they need care? How do we ensure that we do not resuscitate patients when their quality of life is not even good? Do we have a resuscitation policy? Those are the issues we need to know about and to do something about. So the end of life care, how do we do it? How do we support families? How do we address all the dimensions of total care in supporting the families, as well as in entering into the bereavement support? And the caregivers, they need to be supported, including us as the professional caregivers. We need our mental health care to be looked after. Do we have a debriefing sessions when we have had a challenging condition on our wards or on one of the patients we look after? That left us really wondering, we could have done this, we could have done that, and it left us emotionally and psychologically challenged. How do we have any platforms to share our emotions and ventilate so that we can support ourselves? Do we have the counseling support services or staff support systems? We don't have. So we need to do something about that. What about the research? Because that is what will inform the policymakers when we have got the evidence-based and knowledge about why we are driving for policy change, why we are driving for asking for more funds to cover palliative care initiatives. Now, who can provide palliative care? Anyone, each of us, from all the professionals I've been mentioning. That is why the general basic training on palliative care is for everybody, so that we can go back to our individual practices, trying to impact what we deliver daily, whether it is policy making, whether it is actually the day-to-day running of the services to address the issues that the patients and their families face in the dimensions of physical, psychological, spiritual, as well as psychological. But if that approach doesn't seem to address all the issues, then we need to ensure that the general palliative care practitioners, then they get access to this patient, they are referred to them. That is why at Starlight, we have built an app whereby all the clinics, all the hospitals, all the people in the community will have access to refer themselves as patients, families to refer their loved ones, and practitioners at the front line to refer their patients, to highlight their challenges around all those 4 dimensions where we can play a part. But if those patients need the specialist care, we know Dr. Hassan at Sankatana, we have got palliative care. They are still on an ongoing journey to increase capacity of their team. We have got a charitable organization, I don't know if you are aware of, that is only providing care, I think, to about 4 villages in Berea. It is called Najojo. And we will be there as well on the ground. And we are hoping to be in operation soon. And that is where we are. Then we have got the model of palliative care that there are so many models as research continues. And we have now got the latest one that is a bow kind of model, but I want to go to this original one. I think this is the second version of the model. With it increasing the capacity around the screening, we will be able to identify patients, whether they've got hypertension, whether they've got kidney disease, whether they've got diabetes, through all the screening that we need to increase and scale up. as well as identifying the cancer as early as possible, like the programs that the health is doing around the cervical cancer, breast cancer, and every other cancers that we are able to diagnose early. Then if the patients already have physical challenges, then we do all the tests as we'll know to establish the diagnosis. Then we started the treatment that will be intended at curing the issue. But if it's a chronic issue, which is mostly the case, then we have to already think around palliative, and hence why there's an overlap at the start of the curative care, that palliative care starts at the point of diagnosis. Then if we see the options are limited in the curative space, patient can no longer return to Bloemfontein for their chemotherapy and radiotherapy, then we intensify and increase the capacity around supporting the patient in the palliative care space, addressing all those total pain model dimensions. And if there's no more return to this journey, we just have to change lanes and focus on comfort care, support the patient and their families, and ensure they have got symptoms are managed well and pain, and provide counseling to the family, and that is the end of life care. And as soon as death is there, we will have prepared them with a pre-bereavement counseling. Anticipatory grief will have already started the moment they learn that the illness is taking a new turn, that they are no longer having curative treatment. So we have to continue that bereavement care. I am sorry, this PowerPoint is long, not that long anymore anyway. Palliative care and rehabilitation being the subject matter for the purpose of this afternoon. I have to read it. It's quite a busy slide, but I just couldn't see how to really cut it down without distorting the message I wanted to bring across. Disability in patients with advanced cancer often results from bed rest, not only from cancer, from other chronic conditions. They become bedridden, deconditioned, and they also experience neurological and musculoskeletal complications. Now, these terminally ill patients have high prevalence of weakness, pain issues, fatigue, and dyspnea, in addition to other symptoms. We have to find the rehabilitative way of addressing these issues, whether it could be through occupational health interventions, where they will be taught skills around pacing, so that they don't try to do a lot when they are in pain, so that they can do things, whether it is just a simple having bed, giving themselves a bath, or waking around the family, or doing a simple task at work, or even at home if they are no longer able to work, or even the children, so that they don't go out to play with other children when they are still in pain. Probably after they've taken the dose of their medication, they can just manage the task so that they can manage this breathlessness or even fatigue of unexplainable nature. Then palliative care and rehabilitation, they do share these common goals of ensuring that patients are comfortable and they are actually kept at ease. Then we need to focus the therapeutic approaches as a multidisciplinary team to ensure that we have got a tailor-made care plan that will address their issues in a broader sense, from the pharmacological aspect, the medical aspect, the nursing aspect, and the psychological aspect or chaplaincy aspect. All those are dimensions to ensure that we maximize the level of function they can have, or they can be able to be comfortable. Physical function and independence should be maintained as long as it is possible to improve for patients' quality of life and reduce the burden of cancer and that of the caregivers. What is the forward movement from now? We are talking about these goals of medical care, where we have mentioned earlier that we have to change lanes from curative journey to palliation, whereby we just manage the symptoms, pain, and provide comfort. So if the curative lane is no longer really relevant or applicable, We have to aim at prolonging life of good quality, managing the symptoms, providing comfort in the mental space, and also ensuring that everybody relevant is given support. Now, as I've been mentioned too many times, it's about multidisciplinary team. Nurses cannot work by themselves there and say they are supporting cancer patients or non-communicable victims, but we have to work as a team. We will be different specialists with a different background and different dimensions and perspectives, but we have to work towards maximizing comfort and quality of care for the patients and their loved ones. Whether it is at a primary level, community level, preventative measures, maternity and children, whether it's in the pediatric palliative care, whether it is in the intranatal palliative care, whereby somebody is already aware that they are expecting a child with a gross congenital deformities. They need counseling, they need support. Whether the child is actually born with a cerebral palsy or other issues, they need support and palliation. So whether it is around a mental health space, it is still palliative care, and we need to work together. Pain management by ladder in the palliative care space, which will need to empower our practitioners as we tailor-make our trainings. It's about ensuring the distinction between children's care and that of the adults. The adults, we still maximize the 3-step ladder, which was first discovered around the 60s. I think it's 1967 when the World Health Organization came up with this ladder. But later on, it was discovered this cannot be applicable in the sense of the children and the young ones. So we don't have the middle step. We just, if the paracetamol and other medications in the NSAIDs like Brufen are not really working to relieve the pain in children, we just go straight to morphine. So that is the challenge for us as Lesotho. How do we make that morphine accessible and available, as I mentioned earlier? As I stated, Starlight has got the Starlight app. You will just download it to your Android or to your iPhone. We have gone through the phases of testing. We are at a stage whereby we are linking it with the government interfaces so that we can have some second level of security and identification verification. So it will be publicly announced for the nation soon. So that is it. And I just want to say I'm grateful for the privilege that our Minister of Health, through all the officials that took part in acknowledging the need for palliative care in our nation by working together in partnership with us, not only us, but other organizations that are trying to support patients with non-communicable diseases, mental health issues, cerebral palsies, cancer issues, and all the different challenges. If you want to walk fast, you go alone. But if you want to go far, you go together. So we are here to collaborate, to teamwork, building the long-term trust that we can really have our goals, our vision for the nation, our values aligned in order to work as a team to increase performance for our kingdom, for our people who are suffering, who don't have energy to be going to all these different radio stations to share their challenges. They don't have access to social media to post their pictures of how cancer has affected them or other complications to gain sympathy and instant donations from the public or corporate organizations. So we are the mouthpiece designed, purposed, and ordained by the Lord to really advocate for these communities, these vulnerable people in our communities. Imagine somebody from Jesus Mongo, how would they even have money when they have already lost job, unwell, in pain constantly, 24 hours a day, to come to any of the radio stations hore a tlo kopa hore ha re na dijo, re lahlehetswe ke mesebetsi, re hloka di-pads, because there's this challenge. There has to be somebody to make that noise. And I'm grateful that we work together to try to make it together and use our brains collaboratively with all the needs, all the abilities, knowledge and skills and experience, expertise that the Lord has entrusted in each one of us to collaboratively work towards addressing these sustainable development goals. As we know, our own health is SDG 3. If we address it well, attend to the health needs and the well-being of our nation, we will definitely address SDG 1, which is about poverty, because there will be no generational poverty in families. If we support them to have a good pain management, give them good total care pain, addressing their psychological aspects, they will not get depressed, they will not give up hope, they will live longer and be resilient, they will be persistent and patient with the treatment journey, they will really be committed and determined to make it. And that will mean somebody can still be able to live longer. If that is somebody that is one that is the one providing for the family, then they will continue to provide for their family. Children will go to school. Families will have food on the table, roof over their heads, and there will be a cut of that cycle of generational poverty. Because if one, for example, is a breadwinner, they lose their life through non-communicable diseases, and because they didn't get much of the help that could have changed the trajectory of their disease, it means then they can live longer and then provide for the family. But if they die early because they gave up on hope, they could not go on with the cancer treatment, they could not go on with the dialysis, they could not take the medication, they gave up on medication. They said, what is the use? It's already, my kidneys affected. What is the point of taking metformin? What is the point of taking hypertensive medication? Then they suffer stroke, they suffer other complications, they die young, and then their children, one is thrown in the mountains of Tabaseka, Alodisa. One is thrown into somebody's house, Alo Sebeta Malapeng. One is taken by auntie, Alo Musebedisa Hostala Lebana Bahai. That family is just in a non-ending cycle of poverty and future that is stolen from those generations to follow. Just a reminder that tomorrow being Friday, it is an International Children's Palliative Care campaign around raising awareness that not only the adults suffer palliative care issues, even children have got cancer, even children suffer congenital diseases, even children have got chronic life-limiting conditions, and we have to be aware and mindful that they are in our communities. As we develop policies, as we develop programs, as we design the trainings, we have to think of the parents that have got children with life-limiting conditions. And you can wear your hat tomorrow, raising awareness that those that go through cancer journey, they will have to wear their hats as they go to school, as they play with other children, because as they go through the chemotherapy and radiotherapy, we don't want to have them exposed to too much sunlight rays, too much of the rain, and ensure that they don't suffer the adverse effects of being exposed to water or rain or even excessive sun rays. That is tomorrow. Not forgetting that on Saturday is an awareness around the palliative globally. And it's about compassionate communities working together around palliative care, making it accessible, and being compassionate about all that we are trying to do, not just what is my take or what is in for me, but what can I give in my time, in my generation, with the skills and all the knowledge that I've been gifted with, the deposits by the divine power in me. in you, in everybody, in us. How do we make it possible that Lesotho can never be the same, with you and I being part of the frontline professionals? Our parents are too old to make a change. Some of us, as I've mentioned, they are not even alive now. Our children might be too young to capture the vision for the entire nation. It is me and you, and I, and you, and we, that we can make a change as compassionate communities. So that is the World Hospice and Palliative Care Day. Unfortunately, because of other engagements that are raising awareness about palliative care needs in our kingdom in Lesotho, we had to extend our time in UK. We had hoped we would be in Lesotho by this week, so that all these commemorations, we can be with you to share them together and increase the awareness in as much as we can for the nation and the entire public to be aware of what we are trying to do within our partnerships. But we are hoping early November, first week of November, we can do all this together by God's grace. Now, this one was only out of an appeal to say, in your own capacity, as an individual in that room, and our colleagues who listen to this clip, it is upon time now, not yesterday, now and tomorrow, that we can capture and be compassionate to those that are suffering, that we can capture the vision to make our healthcare system improved so that it can deliver the world-class services without looking at the limitations around money, because most of the things within palliative care, they just need the change of mindset. Money will follow. As long as we have really seen the need for a change, inquired in the evidence-based literature of what is needed, and then we can tailor-make all those needs, and anytime there's a vision, the rest will follow. Because in the provision that we will be looking for, in any vision, we are given that purpose, that we can find ourselves trying to play in the multitudes of all the expertise and the experts. What is your part? What is your role? What difference can you make? If you take it being the purpose that you are in that space, in that career, in that office, in that specialist role, for such a time as this, just like Esther in Esther 4, verse 14, that she was reminded by her cousin Mordecai that you are in that palace for such a time as this. The Jews, it is our time. Within our capacity, our job description, and advocate for change and collaborate, and we can go far for the benefit of Mosotho. Who is that Mosotho I'm talking about from the start of this presentation? That Mosotho can be me and you, God forbid. That Mosotho can be our children, God forbid. That Mosotho can be any of our relatives, our loved ones, our colleagues, and our neighbors, anybody. And we need to make the services to be really the ones that would address the needs. Just tailor them as if you are making them for yourself. Simply because I have had an encounter at my workplace a couple of years ago at the start of this journey. I was looking after one gentleman. He was in his 80s. He was 86. And he was unwell, bedbound. And he had other chronic conditions. He could not even hold the cup to feed himself or even a spoon. And I was just propping him upright, sitting him up, controlling the bed using the gadget that controls the bed. This electric bed really gave him a comfortable position that maximized his swallowing. Now, as I started feeding him, he just kept me holding that teaspoon in my hand as I was trying to give him the pudding. He said, "Let me tell you one thing. This is the bed that I've been part of, the pioneering engineering team within Birmingham in the early 60s, as we designed the beds to address the challenges around the healthcare professionals that were complaining of backache, being doctors, nurses or pharmacists or anybody looking after patients, because the beds were traditional hospital beds that were just low. And if you have to watch the patient, it's as if you are bending. And if you are tall like me, then it means the backache will always be a challenge until you even opt to even kneel down. And sometimes even kneel down, then you are too low for the task you are trying to do. He said, we designed this beds. We worked tirelessly day and night. Now, I cannot thank God enough that he used it to inspire my brain with the knowledge and skill that I had at the time to work with the other team to design these beds, because now I'm the beneficiary of all that I thought I was doing for other people. So palliative care, as we go forward and try to maximize, to make it practical, it's not about Marichabalpian. It's not about a Starlight, because Starlight is the name and a mandate and a ministry for the Lord, for his people that are suffering. It's not about me. It is about us. It's about the nation. It's about our kingdom. It's about our citizens. So I'm just really, really calling and inviting you to do your part in this time and era and generation, so we can do all we can, by all the means we can, in all the ways we can, in all the places we can, whether community, hospitals, educational center, district level, community level, hospice level, at all the times we can, to all the people we can, rich and poor, young and old, educated and illiterate, those in the suburbs and in the rurals of the pockets of Lesotho, in the hard to reach, places, Haisus Monko, Kacha, Mokotlo, Tabasek, Tanyaku, Dilidil, as long as we ever can. These are the wise words from the founder of our Methodist Church, Baptist John Wesley. Also, it is always seeming difficult and impossible until it is done. These are the words of Nelson Mandela. With these words, I'm just saying, how can you help? How can we help? How can we collaboratively do it for the benefit of everyone? And this is our website. This is our email. And I can only invite you to ask where we can just have clarity, explore a forward way. We are here, you are servants. We are listening, and we are listening from the patients that contact us through our WhatsApps for support all the time. For the cancer survivors that we have got the WhatsApp group for, and we know their challenges. For the healthcare professionals that we have now got so many of them on our WhatsApp groups per district, per specialist, and per profession. How do we work together? To design this program you are involved in, we will hear from you. How can we be of greater source, working together with you to make it happen for the Mosotho? Thanks to the one that gave us time together to share it. The giver of time be glorified and honored and uplifted, for it is not by might, by power, but it is only by his spirit that spoke through me. He says, open your mouth, I shall fill it with my words. I believe the Lord has spoken. So I will stop the sharing, and we can hear if you want to say something. God bless you and thank you. I submit.
Any questions?
Yes.
Ish, I'm not sure because now.
Can you hear me?
Let me see if I can do this.
Well done, me. Ke a leboha.
Thank you. One good one.
A move laptop hanyane ke tseba ho bona sefahleho. Perfect. Ke a o bona ntate.
No, thank you. Thank you for the elaborate presentation. Actually, you are in the road, and we are in the boat together. So the crash of the Muka owner today, Kia Hubale, very, very, very well prepared modules for palliative care, because we like how you are also putting the capacity for the healthcare professionals. So that's what we are trying to do now. I hope you'll work on that assignment as well with the other team. I will tell you which team it is. Meeting on Lesser State. She knows which team is working on that. And because all the modules, palliative care is cutting across. I'm gonna get like you have presented. So now, yes, it will be intended for training the healthcare professionals down there at all the levels of care. I'm gonna get, and now also, yeah, you can also have the one that is tailor-made for the advocacy. That is what I'm giving you the light why you were invited to make a presentation. It's because you are in one of the group that has to prepare the modules so that we go down and implement. Secondly, yes, you have shown the model that you are using and pain management. Yeah, we still have to capacitate our people with all those tools. Please do this. When you talk about pain management and pain assessment, because it's a multidisciplinary one, if you have got those tools, only there on the tutorial side so that we can be able to use them, okay? You know, those phases with assessing the pain, and then the different scales that we're using. That is the plea on the side of us, because we want to have that document prepared. Now I'm putting my comment on your presentation. Thanks once again. But what I also want to say, we don't have rehabilitative platforms as yet. So we'll be very happy to have the palliative care and rehabilitation on the platform. It's non-pharmacological now. That's why we invite all the other people, music therapy, spiritual therapy, psychosocial therapy, and nutritional, and all that platform will be needed, because we need to make sure that the sectors of the community they get engaged, because they have got the skills, yes, but they don't know where to use those skills. So now the calling is there for them. So let's innovate on that. Little about yoga and things like that, NLP and the rest. The first one was how do you want the modules to be prepared? The second one is just a comment on what is making. Thank you very much. And the sustainability. And the sustainability, because we keep on reinventing wheels.
Thank you, Ndati. Thank you. Ha ke tsebe gona ke tla tataiswa gore ke di arabela hong kapo re nketse pedi di comment be ke di arabela hong kapo one at the time.
No, it's like this. The first one, it's an expectation module batla eng. So you don't have to do it now in this presentation. Again, the second one was just a comment, then you can add on.
Okay, Ndati. Ya ke a leboa. Ke ne ke re fela ke leboe ka mantswe ya hao Ndati. And I think in terms of implementation, ke nahana hore mona mo re leng hona teng, some of us in the room, maybe you are already aware, as I have mentioned earlier, of the ongoing Project Echo training. So I don't know how you would feel, so that we do not seem to be running many programs together, exhausting our energy and our human resource, when we could just collaborate on one platform, maximize and empower it so that it addresses all the issues we want to do. I have already submitted the curriculum, the palliative care curriculum, to the Project Echo at the Ministry of Health, which will address the topics of hypertension, what is the palliative provision within challenges of hypertension, diabetes, epilepsy, mental health, dementia, and learning disabilities or people with disabilities. They are already there. And then the rehabilitative side, we can work together with our occupational health therapist, physiotherapist. As you rightly mentioned, that it is about the non-pharmacological approach, whether it is through music therapy, aromatherapy. We have got a volunteer already that pledged her time. She is in University of Cape Town, who wants to partner with Starlight, just freely come, no payment, but to see how she can support, empower and train people on aromatherapy, music therapy, and like you mentioned, psychosocial support. That psychosocial support as we drive the trainings, because if we do the trainings, we have to also run them in parallel or in collaboration with our implementation strategy. How do we, Ndadesi Jojo and the other officials in the room, Mema Dafita and other officials that I didn't have the chance to know each one of you, but believing you are in key roles in your positions. How do we work together to raise awareness within the ministry or even as partners to really bring it to the table that the country is having challenges in some of the areas. And one of the things we can use is to make sure that we reinstate clinical social workers within our healthcare facilities. 2012, when it was believed the Ministry of Health and Social Welfare was too big to address the challenges of the nation, and then they went separate ways. We last had the social workers social development. But now we are talking about a multidisciplinary approach. We need those social workers in the teams, within the health facilities, within the district hospitals. Jwale hana le tšhelete ya go patala, jwale o bonagalana le depression ebile a go lahletswe ke mosebetsi, jwale ha ana support ya mothwalo mo ka mane motseng, jwale o na le all these psychological, physical, social and spiritual challenges. How do we support them? Now ke mane mo se geutlwa se bonagalang, because even if we were to set a multidisciplinary team, ka hara dipetlele re na le fela team tsena batho bana ba bang ba ka formang team ha re tlo set up palliative care teams, but jwale di social worker di ntse di le mane, ha hona tsela eo ho na le the bridge formed between the two ministries hore di sebeletse ho bona hore di sebetsa mmoho, hore ebe ho na le clinical social workers, ho na le memorandum of understanding and the partnership between these two ministries, hore bona hala rona di social worker ha di sebetsa ka hara dipetlele di tla bentse di sebetsa tlasa Ministry of Social Development, but the social responsibilities tsa bona le job descriptions tsa bona ha ba le ka ga di team tse ka ga sepetlele di laolwa kae, ba reporta ho mang, ba sebetsa jwang, hore ha ebe ba hloka wa setsa mokudi enwa hore jwale ke enwa hana le tšhelete ya ho patala, but ihlile a santsa a le bankrupt, a le poor, ba tlameha jwale ha ba qeta ho setsa mokudi eno ba etse escalate hore ho be le office e designated for people with a life-limiting conditions, because in palliative care, we don't have much time to make things right or to have second chance to make things correct. We only have one time to make things right, because that might mean the patient is only in the last 2 months of their lives. We need to get their social situation sorted. In the terminal illness. Who tries a ranka banaba under age back in school. Now, hunale orphanage, kabanting how finyani ekabashokomela. Now, hunale a responsible and a close member of a family, yakabang committed to look after them as long as social development, eka referale in Kanako, who rebat ba school fees ba provide recadijo and other things they bad shoka. Now, rebaka situation yena yo, kaharena the social workers in the hospitals. But wana badia of mana tuso to a point that one how fungwana case yena kara case loti etelele ya bekulo kutse bana litson. Bana ba se ba bile ba hasantswe mme wa bona ka ponta to bona o sabile a hlokaetse ho so bile o so sena mogwa ba recover e mo sabile wa ngwanana a tsamaile le mohaisane ha tlile Keresemeseng ka popa sekeng a ile le yena Bekestala ka potebena re mo isa difemeng isele human trafficking isele slavery isele sex working isele ntho tsena kaofela. So ke kopa ke re ka potsong ena ha ntate ke hapelle hore can you note that as you are key people in the room, how can we convince and create platforms to make our ministry in a bigger role, that we need clinical social workers. That is the heartbeat of what we see being pivotal to make change for the patient. How do we now have the pastoral counselors and the spiritual counselors or chaplains in the hospital settings, in our healthcare facilities? So far, I'm aware that Maluti Hospital has got a chaplain. Scott Hospital has got a chaplain. Our Pare Hospital has got a chaplain. I'm not sure of other, but I can just see a pattern in the child hospitals just because they are religious organizations and part of their ministry is towards the spiritual health of the people they serve. They have got chaplain services, but we don't have them in our own public services. But that is very much needed if we are talking about spiritual well-being of the patients and of the caregivers. Jwale kere module tseno tse re buang ka tsona tseo re sentse re di provider for our own Project Echo program, or the ones that are intended for the Ministry of Health, a Project Echo program that is reaching all the districts. I believe we can just try and improve on them rather than to create something new. I don't know if I might have addressed the issue, but you can make me understand.
Because that's part of our assignment.
That is your assignment that one highway through ECHO. Then even in per sessions, the program with them ECHO. Even the practical sessions which we already established through our partners. We have got the training manuals. We have got the training tools for the participants. Then we do the practical side of stuff, because sometimes the theory over the online, sometimes it does not really impact much. But if it can be a taster, and then we have for the budget through your programs that we do practical on the ground per district or however you want it, I think we can go far and quicker.
My team about one man.
Thank you. Any more questions, comments, suggestions? Matafita, here. When she's using the other one. I put the echo. Presentation how can you take the comprehensive in the area to so like it a more sense of so clear and that this is when sending our name maybe. They are like what with that I'm saying at and that's the this is the seminarity get a presentation a comprehensive. Who look at where how many come so. When I listen to play ministry, was our own. Ya leboha.
Ke lebohile okay, sorry mme. Utlwa ka mme ona bua.
Ene ke bona e etsa ntho tse di tjena.
Oh. Ntse ke utlwa empa fela ile audio e nyametseng ke a kgola ke bandwidth tsa hao tse ka nna ba di limited ka nqeno. O boetse o hlaile hape. O ka bua mme.
Ne ke re ka nnete re lebohile, ha ke batle ho bua taba tse ngata hobane ke ke senya ditaba tsena tsa rona tse monate. Se re tla utlwa ha ntse o bua pele, re tla sebetsang jwang akere ntate Sello sa itse ka hanyane hore ntse re tswela pele. Re ne re shebeng diphodile tsena ka ho fapana.
Eya mme.
O sa tla ho romella tse ding tsa ditaba ne re bueng re pele ra le bone.
Ka nnete ke a ikokobetsa le nna ke leboha haholo to be of service and to be with you to share this time. And if there are any takeaway points, it's just to know that we are all in the journey together. We are a multidisciplinary force that is intended for the good of the nation. And we need the clinical social workers, number one. We need the chaplaincy service within our healthcare facilities. We need morphine. We need to actually support the carers, including the informal as well as ourselves being the formal and professional carers, through the mental health ways that we can apply, whether it is pastoral counseling or debriefing sessions. And ho sebetsa le di-social worker ka tsela e tla ba straightforward and cut across ka tsela e nolofatsang hore bakudi ba fumane ditshebeletso ka nako. E tla ba molemong wa rona, ba fumane di-wheelchair ka nako, ba fumane di-grants ka nako, ba fumane all the support ka nako. Jwale ke re fela ka nnete ho leboha nna. If we may have for your minutes, Mme Matafita, I wouldn't mind bo mme le bontate ha ka ba itlhalosa hore na ke bo mang ba sebetsa kae. It will give us a better taste of where we are and who are the key players. And again, if you have got their numbers, it will be wonderful whenever you are ready, because we need to link up and see our paths and how best we can customize our partnership as we move along. But being yourself and Jojo and your department being the main focal points for our partnership, being the face and the representative of the ministry.
But then Carlos a mera bua Sotho kaofela.
Ke a leboha ntate.
She means you wanted our names and numbers from the minutes, not to introduce ourselves now.
Both mme. Ya introduction ke ka e thabela le ho feta ka mantswe ya lona.
Okay, we can be fast, guys, so that we continue with other
Programs. Yes.
With other last topic. Okay, Eric, so that Baskema Shebisa Hobona. Bitolaka ke Mama Khalachija, Kesebeta Solida Med, as NCD technical advisor. We are based in Botabute and Mokotlo.
Hello, my name is Dr. Leposet Kore. I work as a project director for HCP-Lesotho, but also supporting the NCD department within the Ministry of Health. Hello. I'm Moda from the hospital, working at community department.
Kina ya ne renentse go bua go no ke re fala nne gore ke tshedimageng ke ngaka mane beile
Ha ke bone ke mang a hlaileng ke mafahla anda to molao
Ke Morena Molao. Ke sebetsa tied to care tlasa program e bitswang Bonolo Meds.
Ke a leboha ntate.
Mpotole jaha ke sebetsa NHTC program ya NCD.
Ke a leboha ntate.
Hello, man. One favor here, get at the moholo. NCD.
Ke a leboha ntate.
Ha wa hla. E phamisa letsoke ba. Ah, mme Mpho hlahile ke a bona. I see you here.
Oh, Mpho o la ba frozen ha o keta o bolela bitso la pele. O ka tjho hape. Ya go network e la re lahla.
Oh, ke Mpho Khiba. Ke sebetsa at Health Department ya monitoring and evaluation.
Ke a leboha mme. Ke a leboha. Oh, it's frozen. But in se ke utlwile mme Mpho ke a leboha. Eh.
Hi, ke Maleng.
Eh, itlhalose kaofela ha ke a utlwa.
O hlahile.
Ke Maleng.
Oh, helang. Modimo ntate. Oh, my dear sister, ke a leboha, ke a leboha. Ke a leboha.
Okay. This side.
Hello, from NHTC, the General Nursing Program, responsible for clinical teaching.
Wonderful. Ke a leboha mme.
Ah, how about this? Doctor.
Yeah.
Ke a leboha mme.
Hello, ma'am. I'm Dr. Kalamba. I'm a dentist working in the Ministry of Health.
Ke a leboha mme.
Hello, ma'am.
Hello mme.
Oh, I'm Dr. Navo Mariale. I'm working with the ORF program in the Ministry of Health headquarters.
Thank you mme. Thank you.
Ke Ntate Mxakaza, lebitso la ka la pele le bonolo ke Thato, ke Health Promotion and Social Determinants of Health Officer WHO.
Wonderful, wonderful. Ka nnete. E ka ba ke batla kgang. E ka ba ke batla kgang ke lebohile haholo bomme le bontate ka monyetla ona mme morena re itse hantle.
Continue with
A re fe matla le
program.
bohlale.
Mme ra leboha.
Ke a leboha, ke a leboha. Bye. God bless. Bye. Bye. Bye.
Bye.
Bye. Thank
Bye.
you. Bye.
Bye.
Bye.